I'm Eric Alexander, the Executive Director of the Brigham Education Institute. It's my pleasure to speak to you on the topic of the Mini-CEX, the Mini Clinical Evaluation Exercise. And I'd first like to give a brief overview of both assessment and evaluation and what the differences between the two terms are. We'll then talk about the specific assessment tool called the Mini-CEX, what it is, how do we do it, and why should you do it. I'll then invite you to watch a Mini-CEX that has been recorded. Let's jump right in. Let's talk first about the differences between assessment and evaluation. In the field of medical education, assessment is considered one piece of information, and it can be used in both a formative or a summative fashion. Every assessment tool has its strengths and its limitations, and we acknowledge these up front. But an evaluation is meant to derive from multiple pieces of assessment or pieces of information. It is usually used much more in a summative fashion, and it seeks to be both accurate and reproducible. So if you will, an assessment or an assessment tool is something like a Mini-CEX, an OSCE, an oral exam, or a multiple choice exam. But the evaluation is thought more so of the student's grade. As I mentioned to you, there are multiple different assessment tools or means of assessment. I've listed just 6 of them here. The Mini-CEX. What is at the top here, the clinical performance assessment. This is often considered the assessment tool that we send out when a trainee has been working on a team for 2 to 4 weeks. We ask the attending or the resident to send back information. Or a multiple choice test, oral examination, an OSCE, etc. One thing to mention is that there exists no single best means of assessment, but rather multiple varying and yet complementary assessment tools usually produce the most valid evaluation. And that is really demonstrated, I think, here when we think through the pros and cons of each assessment modality. On the y-axis, I will list a series of assessment modalities, and then on the x-axis, the various assessment characteristics. Let's look at this. You'll note here the modality 1 is the clinical performance assessment from the wards, the Mini-CEX, the oral examination, or a multiple choice test. And on the x-axis, we can begin to look at whether they assess broad clinical knowledge, verbal communication skills, or here at the far right, history and examination skills, or clinical reasoning skills. In the middle, though, we can also think, what is the ease of doing this assessment, or the reliability and reproducibility of the test itself. I would encourage you to now pause the presentation and take a closer look at least our assessment of all of these variables and how you might think about your assessment tools. One can also think about the value of different assessment tools in the process of understanding learning itself. We often speak to the very important concept here as depicted by Miller in the learning pyramid. This is taken from an article by Casanova. For most of what we do for trainees along the continuum of medical education, we first start out by asking them to know something, then we ask them to know how to do something, ultimately showing how to do it, and then doing it effectively and safely. And what you can see here is that different assessment tools can give you insight into different levels of this growth pyramid. Let's turn our attention now to the actual Mini-CEX itself. What is it? Well, until 1972, the American Board of Internal Medicine required an oral examination for all of its participants to become board eligible or board certified. But this was becoming too onerous given the extent and numbers of tests and the difficulty in producing them and cost, so it was abandoned. And at the time, the ABIM then delegated the task of evaluating residents' clinical competency as they became board eligible to the program director themselves. A task force was then created that recommended that each program director and each program perform a clinical examination exercise that would really take the place of this oral examination. This was a long test. It was a 2-hour or more high-stakes observation of a single encounter. Faculty would watch over the trainee. It was a one-on-one process. The trainee would then write it up. The faculty would provide feedback, and ultimately the faculty would write a letter to the board certifying that this had been done and had been completed satisfactorily. But it was too much. It was too singular. It was one-shot deal. It was too subjective, and it just really wasn't working too well. And that is really the lead-in to then what was proposed and then published in the mid-90s. A group from the ABIM first published this article regarding the Mini-CEX. The first author here, John Norcini, and I draw your attention to the original publication in 1995 and the follow-up in 2003, both here in the Annals of Internal Medicine, where the Mini-CEX was first proposed. Well, how do you do it? What happens? It's meant to be a one-on-one encounter with a faculty overseeing a trainee, and it's meant to be real-world in the live clinical setting. It's not an OSCE where it's much more standardized. The Mini-CEX can be performed in any location, inpatient, outpatient, emergency room, and its focus can also be quite broad. Typically, it's focused on the history or physical exam, but it could also be focused on clinical reasoning and management, and it's meant to be somewhat efficient and focused, typically about 30 minutes on average for the encounter. You can tell, however, that when you create something that is quite variable and short, that a singular assessment may not then be too representative of the trainee, and that is the goal here of the Mini-CEX, is not just to do one, but to have many Mini-CEXs of a single trainee over the course of time. I'll emphasize here the adaptability and flexibility of this assessment tool. It can be done in any location and focus on any part of the clinical encounter. That's a good attribute, though some have also questioned whether it's simply too broad and needs to be refined further. But why should you consider doing it? What's the benefit? Well, it has many strengths, and as we've gone through, it's both easy and efficient. It's very doable without actively disrupting kind of the clinical care paradigm. It also begins to operationalize assessment. It gets people doing it. It's also real world, it's in a clinical setting, and it's more organized than just providing a clinical performance assessment of the trainee. But it does have its weaknesses. If indeed it's too unstructured or too vague, then the findings become less helpful. They're kind of just one unique experience. And as I mentioned, it is important to realize that many Mini-CEXs are required to make this test reproducible, to gain the most consistent evaluation on the trainee. And typically in the published articles, that number was 12 to 14 Mini-CEXs over the course of a year, but the authors do note that 4 to 6 even becomes an acceptable alternative. And as is the case with any clinical encounter, it can be unpredictable with regards to patient care. I'm going to share with you here the assessment form, the feedback form that is first provided by the ABIM, and this is available at the website you see. And in orange here, I just note that it is highly adaptable and modifiable to the clinical environment. This is the back of the form. But what I really want to emphasize here is how you can adapt the Mini-CEX to your educational environment, and I think in doing so it becomes even more useful. I'll give you one example that we used here. At the Brigham, we run what's called the Principal Clinical Experience. It is the year-long educational experience that encompasses all of the primary clinical clerkships like medicine, surgery, pediatrics, obstetrics, neurology, psychiatry, and radiology. And so when we were working on assessment of our students, our objective was to add another means of assessment that was focused on clinical skills. And in doing so, we wanted to foster some consistent, uniform assessment of students regardless of the clerkship. We also needed something complementary. We already are obtaining clinical performance evaluations from the wards. All students also take a multiple choice test, assessing knowledge in each clerkship, and many have oral exams. But in adding an assessment tool, we also didn't want to make this too high stakes. We didn't want to overweight this, but yet we did want to make it visible, value-added, and sustainable. So I'll show you what we came up with. On this slide, I'll depict the clerkship, in which now we perform a Mini-CEX in each and every clerkship during the principal clinical year, and how they were designed and what the objective was. In medicine, we focused on the history and physical exam with a brief presentation. In surgery, though, it was a postoperative evaluation and creation of a treatment plan. Obstetrics, it was the focused abdominal exam on a pregnant patient. In pediatrics, it was the complete oral presentation of a case. In neurology, it really focused on the complete neurologic exam. But in radiology, they worked on counseling for a CAT scan, both radiation effects and contrast reactions. Psychiatry was focused on a full mental status exam, and in the primary care clerkship, it was an urgent care evaluation. Importantly, we felt that we wanted to provide the students with a one-page set of instructions for each Mini-CEX at the start of their year, so it was very transparent what they would be asked to do, and that they would be asked to do one in each clerkship. I'll show you an example, but first I want to emphasize how diverse the objectives were. We did not seek to always provide and seek the same objective in each clerkship. We tried to adapt it, and we felt over the course of a year we would provide and obtain some very important teaching and assessment of the student themselves. Here's one example of the instruction sheet provided to every student. This is for the obstetrics and GYN Mini-CEX. And here's a second one describing the Mini-CEX in our psychiatry clerkship. And I want to share with you our adaptation of the evaluation form. As I mentioned, we did not want to make this as high stakes, but we wanted still to obtain some useful information. And so we boiled it down to 4 questions. The first is we wanted to make this a necessary component of every clerkship. So we simply asked the question, did the student complete this exercise during the clerkship? We next asked, did the student read the orientation pamphlet and come prepared and arrive prepared for the 30-minute exercise? Very simple. We also thought that regardless of the overriding objective of each Mini-CEX, that we always expected a student to be courteous and show professional behavior. And so we asked the question, during the Mini-CEX, did they meet this expectation? And there was only one other performance question, which did the student display the minimal competency of the requested objectives? And during the course of a year, for each Mini-CEX, we find that about 10% of students don't necessarily meet that competency. We then teach them the skills, and they retest with the Mini-CEX in that clerkship. You'll notice that we were able to shorten down a very long assessment tool into just 4 questions. I'll also emphasize that these were very simplistic endpoints, but yet obtained for us a different assessment piece of material that was complementary to everything else we were doing. I'll now invite you to actually watch a recorded Mini-CEX. This is in the surgery clerkship. I'll note that the student, the faculty member, and most importantly, the patient all gave approval for this to be recorded.
So I know they give you some background about what the purpose of this exercise is. Do you have any questions just right off the bat?
So it's going to be a post-operative patient.
Exactly.
And I'm essentially getting like handoff from you.
Yep,
Okay.
That's exactly right. So imagine that you're the intern coming in the morning. I'm the night person. I'm going to tell you what you need to know about this patient. You're going to take some time, and then you'll go see them, and then you're going to come to rounds and tell your chief everything that I need to know about this patient in order to move forward. A 37-year-old female whose medical history is most significant for ulcerative colitis, refractory to medical treatment. She was diagnosed with hypercoagulability, inclusive of cerebral venous thrombosis, a DVT, and a PE in June of 2014, and has been anticoagulated. And then due to the medical refractoriness of her condition, ultimately decided to undergo surgery. And now today, she is post-op day 1 after an ileostomy closure. So your goal is really to focus on that surgical episode of yesterday.
Okay.
There were no complications during the surgery. It was very straightforward. She had no acute events overnight. And then you're going to pick up with her this morning. Okay, feel ready?
How are you?
I'm good.
Hi, my name is Yuri. I'm a student with surgery.
Oh, great.
I'm just going to check up on you, okay?
Sure.
Is that okay? Just trying to make sure you're doing okay. So how did last night go for you?
Good. It was up a lot in the night, but dozed some this morning, so I'm doing all right.
Okay.
Yeah.
How's your pain level?
It's manageable. Right now it's about a 3, I guess.
3?
So, yeah.
Okay, so manageable.
Yeah.
Is the pain medication they were giving you controlling that? Do you think it's working for you, or?
Yeah, I think so. They changed up the oxycodone, and I think that helped.
Okay, that's helping
So,
you.
yeah.
Great. So, and any episodes of nausea, vomiting last night?
None.
Okay.
Yeah.
Any diarrhea?
No. I've evacuated waste twice, and that's been fine. But that was after I ate today.
Okay. And you told me you're walking around fine. Is that okay?
Yeah. I've been doing laps around the hallway.
Okay. That's going okay for you?
That's going fine.
Okay.
Yeah.
Any dizziness when you stand up, or?
No, but the incision just aches a bit more when I sit up or
it's a little
stand.
more painful. Okay.
Yeah.
Okay. Any shortness of breath that you're having? Anything?
No. Voice is still a little raspy from the anesthesia.
Okay.
So.
But no chest pain, shortness of breath.
No.
Okay.
Yeah.
Very good. Is it okay if I examine you?
Yeah, sure.
Okay. And you're going to the bathroom. You're peeing, okay?
Yes.
Okay. And you're drinking.
Yeah.
Okay.
Probably could be drinking more, but doing as much as I can.
But it's going down okay?
Yes, it's going
Okay.
down fine.
I'm just gonna take a look here.
Okay.
Is there any pain there?
Tiny bit over here.
Okay,
That's fine.
that's fine. And the dress, is it soaking through, do you think? or-
It soaked through the first night, but this morning it's been fine.
Okay.
Yeah.
Sounds good. Let me just take a quick listen to your lungs here.
Cool.
Just relax and just listen to your heart, okay? Okay, very good. Can you lean forward and take a deep
Sure.
breath for me? Okay, big breath. Great. One more time. Okay. Well,
Great.
thank you. The assessment plan for her, she's post-operative day 1, she's doing well with her pain control. She's not endorsing any symptoms now. So for her, really, we're just going to try to oralize her pain medications, continue to encourage her out of bed. She's ambulating. We're going to advance her diet as tolerated. Discharge home without services.
Overall, I think that you demonstrated that you're building a really nice foundation of what information you need to gather in order to take care of our postoperative day 1 patients. I think the next step for you is going to be thinking about sort of those next step planning elements and being able to talk about them. So kind of go to the beginning. Thank you for being on time. You're wearing your white coat, all the right professional set stage elements. I do like to pay attention to what objective data you're looking into. And you took a look at the labs, the vital signs, the I's and O's. Moving into the examination component of this. When you got in, you were very polite, really set the stage well with the patient, which is an absolutely invaluable trait. I thought you really built a nice rapport with her right away, were polite, introduced yourself appropriately. You asked very targeted but open-ended questions and asked all the things that I would have wanted you to ask. Asked about her pain and followed up nicely in terms of, what medication are you taking? Is that working for you? You were able to elicit the fact that she'd had some changes in her pain meds, which is important. Asking about taking food, nausea, walking around, asking about bowel movements, asking about voiding. You got very nice exposure of her abdomen while preserving her modesty. You looked, listened, and you felt, which is the appropriate order in which to do things. And then in terms of the assessment, you did tell me that she's doing well, but I think I'd like to see a little bit more in terms of your plan making and thinking about that next step, like I said. So we talked about continuing pain medications. Which pain medication should we be on? Is it good for her? We think she's on PO. Can she stay on that? Are they doing effectively? Advancing her diet? Does she need any services walking around? And then also the DVT prophylaxis. For this patient, that would be really important. You've done a great job gathering the information, making sure that you're presenting it in a sort of organized, efficient manner that really reveals all of that good stuff that you've collected is something that you should keep practicing with. But overall, I think you did a nice job setting the foundation, and the more you practice, the better you'll be at it.
So in summary, a Mini-CEX clinical evaluation exercise is an assessment tool. And it has gained, though, a lot of popularity because of its clinical relevance and real-world feel, also the simplicity and efficiency necessary to complete it. And finally, its universality to almost any clinical environment. But as was mentioned, it takes multiple Mini-CEXs, typically greater than 6 or 12, there's no magic number, but multiple to allow for improved reliability, precision, and valid feedback on the trainee. It is, however, highly adaptable to your needs, and I hope I showed you an example here within our environment. I thank you very much for watching this video here today.